Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning. How you guys doing, man? I hope you're doing fantastic. I don't know what's going on. I'm getting some weird feedback in my headphones. Let's just get rid of those. We don't really need them. Do me a solid. We've had some audio problems before. We're getting some weird audio problems today, but it's just shooting feedback into my headphones. So if you don't mind, just drop a comment below. Let me know that you can indeed hear me. I hope you guys are doing fantastic, man. It is a beautiful, beautiful Tuesday here in Austin, Texas, and I am excited. Simple show today, man. I got some news updates to go over with you guys, and we're going to dive in to a little bit more of the final rule that they rolled out, specifically in regards to prescriptions, how it affects prescription coverage. Found a great article that dives into it pretty little deeper into that space than I did. A couple of weeks ago, I went through the new final rule. I went through all the points. I want to say there was maybe, I think about 12 or 13 different key takeaways and points that they had on it. But today I'm going to go specifically through some of the drug expansions, or the changes, I should say, that they're doing. So we'll dive into that. But as always, of course, Tuesday Training is brought to you by DFY CRM. Don't know what's going on with these. They're useless today. But sponsored by the DFY CRM, man. That is my CRM of choice. If you're an agent out there and you need a CRM, you need to give these guys a call. The main reason I chose it is because I can use it to run all of my marketing points. Every single marketing point that I need, I can run through one CRM, all very integrated. And my favorite part about it when I jumped on was most of the work was already built for me. I just had to plug in my assets. So if you're looking for a good CRM to kick off next year, something that'll enhance your work, provide you some automations to ease your time, check out DFY. Moving along, you guys probably saw this just recently. It was posted in a bunch of the groups, nothing major, but you get a few extra days to write ACA coverage. So as you saw this, they expanded the deadline for coverage that begins January to now December 18th. So that's tomorrow. But it gave you all a couple extra days for all you guys out there that are writing Obamacare, writing ACA, or marketplace coverage. You get a couple extra days to get that stuff knocked out. So you got until the end of tomorrow to turn it in for January 1st coverage. And obviously, you can do February 1 coverage a little later as well. Pretty simple. Moving along. And this shows, I'm probably a little quick show today because I just got a little bit of news for you guys. We'll see how long it takes us to dive through the other piece. And let's see here. Next up, you guys may have heard about this as well, too. Found this article on Newsweek. Medicare is going to make some changes to coverage under a new bipartisan bill. This has been talked about for a while. I couldn't find a better article than this Newsweek kind of trash article. I mean, the article's fine. I just don't like their webpage because they advertise the hell out of it. But basically what's happening is lawmakers have proposed a bipartisan bill that will now include birth control coverage under Medicare, which means it must be available in the plan as a prescription medication. You may remember under the Affordable Care Act that birth control was required to be covered as a prescription on marketplace and ACA plans. They are now extending that to Medicare. And I know in a lot of cases you're like, hey, wait a second. Why do people on Medicare need birth control? Well, of all the people that are on Medicare, about 1 million of those people are actually pre-menopausal women, right? Not everybody has to be 65 years old to get Medicare. You can get Medicare with certain disabilities under age 65. So about 1 million people are pre-menopausal women out there, which certainly could need birth control. So they are working on again, it's a bipartisan act, so we're getting support from both sides to add this to it. There's not much in the article other than, hey, we got a couple of people in both sides of the aisle who are pushing this bill to get birth control included in Medicare coverage. So I expect that'll probably get pushed through with flying colors. Don't think they'll have any issues with that one. So there's no expected launch date on the change. Whether or not it would come for 2025 is unknown. Maybe it's 2026, etc. But that is something they're working on there. And then moving along, there's been a lot of talk, obviously, with our federal government and the administrative change. There has been a lot of talk about fraud. And I talk about fraud quite a bit on this show. I always love to pull up a good fraud case if I find one. And here's a new one that just came out. The article just came out yesterday. But this specific group of fraudsters, they've been operating for a while, and I actually called them out a while back. And it's the same bullshit it is every time, right? It's a group of either fraudulent doctors or a group of other fraudsters that are working in the durable medical equipment space that are creating fraud through fake or falsified DME orders or genetic testing or cancer screening or any of those. Another one of those stories, but this one's pretty interesting. These guys are pretty what's the word I'm looking for? I guess innovative, maybe. I don't know. They were definitely committed to creating some major fraud. So this article kind of goes through what they did, but it was basically 10 guys, 10 people from Broward and Palm Beach counties used 3 call centers and 3 labs to fool doctors. So they weren't getting doctors to also be fraudulent. They were hornswoggling the doctors as well. But they fooled doctors and they ripped off $53 million from Medicare. And thankfully, now all 10 of them reside in federal prison, as it says right there. But I want to go through this because this is pretty amazing what these guys have put together. Thankfully, we were able to catch it. But it says right here, West Palm Beach's Jose Goyos became the last of the economic gang to be sentenced to prison in December, getting 15 years on attempt and conspiracy to commit mail fraud and money laundering. Goyos will serve those sentences, the group's second longest concurrently. Here's a list of the guys, right? We got Dan Carver, 38. He's got one of the longest sentences. He's at 16 years. We've got Louis Gino Carver, right? Ashley Figueroa, Thomas Doherty, John Paul Gosney, Ethan and Macier, Timothy Richardson, Galena Rosenberg, and Mike Rosenberg, 61 years old. So this group all put this together. What did they do? Well, Daniel Carver's plea described the layers of lies the group used from January 2020 to July 21. So only just over a year, like 18 months, 16 months, these guys did this and pulled off $53 million in fraud, which is nuts. It says Carver owned Boca Raton's DMC Group Holding, Royal Palm Beach's Broad Street Lifestyles and Olympus First Consulting Call Centers and Clinical Labs, Surgena Laboratories, Theragene Diagnostics, and North Miami Beach Progenics Lab. Okay, so he owns 3 call centers and he owns 3 labs. The call centers conducted deceptive telemarketing campaigns targeting Medicare beneficiaries in an effort to obtain their consent to order durable medical equipment or genetic testing, right? You guys may remember this. This was bouncing around the news a lot during COVID. There was a bunch of people doing cancer screening, genetic testing, etc., and pushing COVID tests out as well in the DME space, falsely or fraudulently, I should say, and obviously getting that money reimbursed from Medicare. And Mr. Seiler, no, this is not where you go to reset your Medicare or your Sunfire Matrix password. You would need to go somewhere else to figure that one out, but I can get you the link. Moving along, most notably, the Dr. Chase telemarketers. So they have a group of telemarketers that are calling Medicare beneficiaries to get consent to order DME equipment for them for genetic testing, right? So they got a group that's selling genetic testing to beneficiaries, and they got another group of callers that are calling the doctors. So Goyos ran the Dr. Chase part of the call center. Prosecutor's sentencing investigation report said that Goyos wrote the Dr. Chase manual, including the lies to be told by his telemarketing staff. Most notably, the Dr. Chase telemarketers lied to medical providers by claiming that Medicare beneficiaries were mutual patients and that these patients wanted these tests. Additionally, Goyos was involved in the creation of a website for a front company, Gentech Solutions, which was used to provide medical providers with a false sense of security that they were dealing with a legitimate medical provider as opposed to a call center. Doctors believed Gentech treated the patients. So they were basically calling these Medicare beneficiaries and selling them genetic testing. Hey, get your free genetic testing, right? Free cancer screening, whatever it is. And then they would call the doctors, tell them that, hey, these people are mutual patients of ours. They want access to the test, and basically we need you to sign off on it, right? So they use these Broad Street to pay, and then they set up obviously fake web domains, fake web front, the whole bit to pull it off. Carver, Doherty, and others used Broad Street to pay kickbacks to telemedicine companies to obtain signed doctor orders for the DME and genetic test that were not medically necessary. Then the gang got illegal kickbacks and bribes from labs, DME companies, and marketing companies for the signed doctor orders. All this allowed them to submit 67,422,579 in fraudulent claims to Medicare for unnecessary lab services, of which Medicare actually paid 53 million of those claims. Woo. The case was investigated by the FBI and Department of Health and Human Services, Office of the Inspector General, the prosecution handled by Criminal Division's Fraud Sections Reginald Tyler. Pretty crazy, man. These guys went to a long distance to get that entire operation set up. 3 call centers, 3 labs, fake web domain. One set of call center is calling doctors. One set is calling Medicare beneficiaries, putting it all together, and they made $53 million in 16 months. Pretty crazy. But that shouldn't be that crazy to you, because the truth is, and as you guys have seen, I have talked about and pulled up fraud cases from time to time with Medicare. So I was curious I wanted to look a little deeper. So I went to justice.gov, and I've been to this site many times. A lot of times this is where I've referenced some of the articles from. And I searched all news releases. And then I searched by keyword Medicare. And this is again on justice.gov. I got 2,094 results on that. There are the Department of Justice news articles with the key topic is Medicare. Now, the Department of Justice doesn't post news articles about Medicare that are fun or uplifting or helpful. The only articles that would ever appear on justice.gov regarding Medicare are going to be involving Medicare fraud. There's 2,094 articles. I mean, damn. I knew there was a lot of fraud, but that is nuts. And the most recent one right here is right at the top. Doctor pleads guilty in a $5.5 million COVID fraud scheme. That's December 16th press release. Another one just down from December 13th. Justice Department announces resolution of criminal and civil investigations into work with Purdue Pharma regarding fraudulent claims from OxyContin submitted to Medicare. Here's another one. Another doctor, unlawful distribution of oxycodone submitting through Medicare. And the list just goes on and on and on. 2,000. I mean, I'm 10 articles in, and I'm still only on December 11th of this year. December 6th. Here, this is the article that I was just talking about. These guys that were sentenced for the telemarketing scheme with genetic testing. It keeps going. December 4th, like just November 22nd, finally. But I mean, the list goes on and on and on, multiple pages. $79 million fraud scheme right here. So, I mean, for people to think that like, oh, there's not that much fraud, Medicare, all of the problems in Medicare cost is is these Medicare Advantage plans overbilling, or these Medicare Advantage plans denying claims, or this or that. Like, come on, man. That ain't where all the money's going. There's a ton of issues, millions, I would even say billions of dollars that are happening through fraudulent claims, fraudulent billing, whether it's a absolute criminal organization like this first one, the one that I mentioned today. Like, those weren't doctors that were purposely doing something just to pad their pockets. Those weren't insurance executives that were just creating overbilling schemes to get more money, etc. These were just 10 straight criminals that came up with a great idea. That is organized crime. I'm surprised they only got 15 years, but there you go. So if you're curious about what kind of fraud exists in the Medicare space and you really want to learn, or in any space maybe, head over to justice.gov and go to the news side, do a keyword search for anything you're looking for, apply it. And well, if you search for Medicare, like I said, you're going to get 2,094 results. So 2,094 news articles posted on DOJ involving Medicare fraud. Pretty wild. Moving along. This is what I wanted to dive into mostly today. I found this article on National Law Review, and I went through it in pretty good detail. And I feel like the group, there's a few people that put this together, did a pretty good job on it. Looks like they are spot on. This goes through the final rule for 2026, right? The next one, not the one that's going into effect next year. In 2025, but the one that was just released, the ones that we get to make comments on by January 27th of 25. And if you are an insurance agent, broker, whatever out there in the Medicare space, I would highly recommend that you comment on that article, because there are definitely some things in that article, or in that final rule, that are going to make life harder for you as the agent. There's definitely some marketing rules in there. They weren't absolutely grotesque, but if they get their way, like, it's just continuing to pull on that string of yarn, man. The more power we give them, they don't ever give it back to us. So whether or not some of this stuff is going to get recalled in the new administration, I don't know, but definitely want to check it out. So I'll get this in the group, but I want to go through this with you guys and point out some of the key takeaways they're talking about. This article is not going through the entirety of the new 2026 final rule. This article is specifically going through some of the drug changes that they are expanding on within the final rule for 2026, right? I did a video maybe 3 weeks ago where I went through the entirety of the 2026 final rule. I mean, not line item by line item, page for page, because I think it was 711 pages or something ridiculous. But I went through every point, what they were making, what the purpose of it was, etc. It's kind of a broad overview. You can go through that. I'm going to do some deeper dives on it again. But that was the first of many. And then this article, like I said, that I found from National Law Review is going specifically through changes that were proposed in that rule for the Part D side of things, right? So we're going to dive into some of that. And I'll make sure this is in the group. The first thing that they mentioned in that was that they wanted to expand Part D coverage for anti-obesity medication and covered insulin products. Primarily, this is your Wegovy and mainly Ozempic. Their GLP-1 drugs is what they're talking about. I'm not going to go through this entire paragraph here. You can check that out. But the main crux, and this was the big part that I got out of it, is that for the folks that are prescribed Ozempic or Wegovy or GLP-1 drugs for weight loss, not just for diabetes, right? Like right now, they can only get coverage if they're prescribed those for diabetes. Right? It will not cover it for weight loss. The proposal is that to start covering it for weight loss, because obesity is a chronic condition. That may be arguable. That's the way they're looking at it. So they're recognizing obesity, number one, recognizing obesity as a disease, as it says right there. Number two, this isn't just a blanket, let's give Ozempic to everybody and cover it for weight loss or diabetes, doesn't matter. That is not what it's about. And it doesn't say it so much in here, But when I went through the full final rule and the piece on this, there's a couple of caveats. It's not just like, oh, you're obese and you want to take Ozempic, cool, we'll get it covered for you. There's two other things that have to happen other than getting approved for it, right, under a doctor's order. Number two, they want to see some behavioral counseling that might help prevent your obesity. And they want to see you involved in some form of weight loss or weight management program. So it's not just like, oh, cool, here, you're obese, here's some Ozempic, lose some weight. It is, hey, okay, cool, you want to get this covered for weight loss? No problem. But we want to see some behavioral counseling, and we want to see some changes. We want to see you participating in some kind of a weight loss management program. So it's kind of a three-prong approach. We're like, hey, if you can put these three things together, we will cover your GLP-1 drug for weight loss. Fairly simple, right? Next thing, as we know, is the Medicare prescription payment plan. They expanded this a little bit, mostly just in regards to reporting requirements on the carriers. So just to give you a little more heads up on how this works, if you haven't already heard, the Medicare prescription payment plan is simple. For people that are hitting that $2,000 cap, right? And most of their money is getting spent in the first part of the year. Right, let's say they're on a plan that has a $590 deductible, the max deductible, and they're taking a couple of tier 3 meds, right? So as we know, in that first month, they have to pay their deductible and they have to pay 25% of that tier 3 med. If that gets them to $2,000, which it probably will pretty quick, those are going to be your best people that should qualify for the Medicare prescription payment plan. Right, you got somebody paying $300 a year for drugs, $30 a month, or 20, something like that. That's not the person that you're trying to help with this, or guide, or recommend this to. This really should be designed for those people that are hitting the $2,000 max out-of-pocket threshold, and they're hitting it probably in the first quarter. Right, so months 1, 2, and 3 is when they slam their $2K max out of pocket. They hit the troop, and then the rest of the year they get zero. So it's designed for those folks that can't afford to spend $2,000 in 1 to 3 months. They can spread it out over time. Now, how does it work? Pretty simple. It is on the carrier, right? It is not your job. You can recommend it. You can promote it. You can tell them to look out for materials and tell them to contact the carrier and ask about it. But the onboarding requirements, everything is on the carrier. So the idea, and I can't say that I've seen anybody getting new materials on this. I would assume that there is information on this within their new onboarding documents that they're getting from the carriers this year. But basically, the carrier is supposed to reach out to them and say, hey, Fred, have you heard about our 12-month prescription payment program? It might benefit you. Click here to get enrolled. My concern is how quickly the carriers can get on that before some of these people slam their group that are going to pay it in January. Like, I have several clients whose medications are at such a level that they will max their whole troop out in January.
I think it's the dream.
Whole $1,920, whole $2,000, whatever it might be. They're hitting it all in January, and then the rest of the year they're paying nothing. So I'm curious how well the carriers are going to be able to get this rolled out to them, get them enrolled in it, and actually make it work for them. So for some of those clients, I told them to look out for it. I was like, hey, you're probably going to get something from Humana or WellCare or Aetna, whoever it was, that tells you about this Medicare prescription payment plan. Keep an eye peeled for it. And if you're more interested and you don't want to wait, as soon as I get your approval for your new plan for next year, here's the phone number. Go ahead and call them, get them set up. Sarah Copeland is saying right here in the comments that, hey, my client got all the info mailed to her when they sent her the new plan info. They even sent the application. See, so again, Kara is the one that's supposed to do this. Thanks for that comment, Sarah, because I haven't had anybody tell me that they've received that info yet. But that was kind of what I figured, is that they were going to get it with their new materials for 2025. And then it's how quick can you get that person enrolled? How quick can you get that person approved for it? But the carrier will manage everything. So basically, not only will the carrier get them onboarded, the carrier will manage the payments, right? The carrier is going to take care of all the payments and bill them a monthly rate, whatever it might be, $180, something to that effect.
This is, of course, also
moving
used by
along.
the flight shame.
Formulary
See.
inclusion and placement of generics and biosimilars. So they're putting a lot more pressure on these Part D sponsors to include and create better processes to have a better assortment of generics and biosimilars versus just brand name drugs all the time, right? So it says here, CMS notes that concerns have been raised that Part D sponsors and their pharmacy benefit managers, PBMs, may be engaging in practices that favor expensive brand name drugs. You don't say. And reference biological products over more affordable options such as generics and biosimilars, leading to higher out-of-pocket prescription drug costs for Medicare beneficiaries. This has already been proven
the dream of somebody
that
to live and work in Italy. They should definitely
some of the Part D
pursue that.
sponsors and, more importantly, Big Pharma
I personally
and
think
pharmacy benefit managers have been colluding to keep more expensive drugs on the approval list and not as many generics or biosimilars, right? And they've also been padding costs through their little arrangement that they have there. Because the truth is, I mean, the way I look at it, they want everybody, if the max is going to be 2K, they want everybody paying 2K, period, right? So some people are going to benefit, some people are getting screwed. That's my thought process. Real quick sidebar, Randy Haynes is asking me a question. Do you think Dr. Oz will roll back government overreach? I don't know necessarily that Dr. Oz specifically will, but it wouldn't surprise me to see the new administration roll back some of the regulation. Generally speaking, Republicans and conservatives are in favor of less regulation or deregulation. So I would think that most likely we're going to see a lot of this stuff get rolled back. Whether or not we'll see intricate rules like this get rolled back is a whole other thing. In my thought process, if I had to speculate, I would say if they're going to deregulate or roll anything back, it would be some of the friction on sales, which could be good or bad. And what I'm talking about is things like the 48-hour rule, the call recording rule, some of those things that make it more difficult for the broker. And I could be wrong, but we'll see. But anyway, moving along here, I want to repeat that first statement one more time. CMS notes that concerns have been raised that Part D sponsors and their pharmacy benefit managers may be engaging in practices that favor expensive brand name drugs and reference biological products over more affordable options such as generics and biosimilars, leading to higher out-of-pocket prescription costs for Medicare beneficiaries. No shit. In response, CMS reminds Part D sponsors of the statutory requirement that they implement cost-effective drug utilization management programs. That's your step therapy, right? Exceptions, PA, etc. In the proposed rule, CMS clarifies that planned formularies must ensure beneficiaries have a broad access to generics, biosimilars, and other low-cost drugs in order to comply with the statutory requirement. The clarification expands to the closing or the 2025 final rule, which introduced drug changes or introduced changes to permit more flexibility for enrollees. So they're stepping that up, right? They want Part D sponsors to have broader access to biosimilars as well as generics. Fairly simple. And we want that too, right? As agents, we definitely want that. Because I know a lot of us are tired of seeing our clients blow money on high-cost drugs that are just brand-name drugs. But hey, there probably is a biosimilar or a generic out there that could be effective. Why is it not available? One more statement in here. Specifically, CMS will holistically review whether a plan's formulary and utilization management practices are cost-effective, reasonable, and appropriate, and inclusive of incentives to reduce cost. This would include an evaluation of whether the formulary includes lower cost drugs and whether such drugs are on a lower formulary tier. In addition, CMS would review whether a formulary incorporates fewer utilization controls on brand drugs and reference products that are on a lower cost alternative. So, and it even says CMS would use its authority under Section 1860D, 11D2 to negotiate the terms and conditions of Part D sponsors' bids if a plan's formulary does not appear to provide broad access to drugs. In other words, they can obviously suspend them and keep them from being out there. They can take away their crayons, as I like to say.
The results are in, but
you can hear the ad playing in the background as well, Sonia, because I can't find it. I've been looking at every single page, and I can't find that ad that's running. It's in my headphones. I didn't think you guys could hear it. But I'm going to close out some more pages here. And hopefully that wiped it out. So I apologize. That thing had been running in the background. I couldn't find any ad running anywhere that was producing that sound. So I thought it was a ghost sound, but maybe it's gone now. No, I still hear it. Can't find it anywhere. Anyway, moving along. This one's good here. Just, think of it as just light jazz in the background, serenading us. Moving along, promoting transparency for pharmacies and protecting beneficiaries from disruptions. I don't know what to tell y'all, man. You're just going to have to get through it because it is nowhere on my screen. I've looked everywhere to find an ad that's running. I have no other windows open at this point. So clueless as to where it could be coming from. So no idea. So moving along, we're just going to keep it rolling. Promoting transparency. So 2 new provisions that they've got, right? Fairly simple, and this is based on pharmacy network stability as well as promoting transparency in the networks. So number 1, they're going to mandate that the Part D plans must inform contracted pharmacies that they are in network before October 1 of the year prior to the plan going into effect. Okay. Number 2, they're going to require Part D sponsors to allow pharmacies the right to terminate their network contracts without cause, following the same notice period that Part D sponsors have for terminating contracts without cause. So pharmacies can terminate without cause during that time period as well. And then finally on that piece, they propose to adopt both proposals. Actually, I should say those are the 2 items. Mandate that the Part D plans must inform contracted pharmacies of the Part D plans that are in network before the 1st. And then number 2, requiring that Part D sponsors allow pharmacies the right to terminate their network contracts without cost. Those are the 2 pieces. And they want both proposals pursuant to authority under yada, yada, yada in the Social Security Act to adopt contract terms. Notably, CMS did not address the permissibility of the proposal in light of the statutory not interference clause. So fairly simple contract negotiation stuff there. Medication therapy. Whew, here's another one. Smooth jazz at every training. That's right, Randy. We're going to keep that going. Maybe we'll figure that out and have it running all the time. So under the existing regulations, Part D sponsors are required to have a medication therapy management program. This has always been around. It's nothing new, but they are expanding it or enhancing it, right? And these are designed specifically to ensure that targeted beneficiaries appropriately use the Part D covered drugs to optimize therapeutic outcomes, right? We want to make sure that if you're taking this drug, it's not interfering with that drug, right? If step therapy is necessary, we're going to use that, et cetera, et cetera. The MTM program is also to target enrollees with multiple chronic diseases who take multiple Part D meds, and those likely to exceed an annual cost threshold, right? So we already know that they have the cap. That's good. So effective January 1, 2025, CMS established improved targeting criteria for the program to ensure consistent and equitable access to medication therapy management services. So the Part D sponsors must include 10 core chronic diseases, including Alzheimer's, in their targeting criteria for identifying beneficiaries with multiple chronic diseases. Now, sidebar, if you've ever heard me talk about my speculation on the future of Medicare, and it's not so much on that as it is the future of what our client avatar looks like in 2030, then you would remember that the rise of chronic disease is extremely heavy right now, and that by the time we get to 2030, if I remember correctly, your average beneficiary
It's the dream of
will be
some
living
people
with
to
3
live
chronic
and work in
diseases.
Italy. They should definitely pursue that.
Kidney disease, for example, right? Or diabetes plus heart or hypertension. Hypertension is considered a chronic disease. So like just those two right there, if you remember the stat that I showed you, 79% of all of your beneficiaries by the time we get to the year 2030 will have hypertension and 48% will have diabetes, which basically means almost 1 out of 2 of all of your beneficiaries in 2030 are going to have 2 chronic diseases, hypertension and diabetes. But those aren't the only 2 chronic diseases. There are plenty of others. And then the math checks out to pretty close to 3 is about the average. So they're saying here that Part D sponsors must now include 10 core chronic diseases, including Alzheimer's, in their targeting criteria for identifying beneficiaries who are living with multiple chronic diseases. Following suggestions from contract year 2024 and the Part D rule, which increased eligibility for the medication therapy management, CMS now proposes expanding the regulatory list of core chronic diseases used to identify Part D enrollees who have multiple chronic diseases, right? So they want to expand, one, the number of core chronic diseases that are in there so that they can encompass more people, take care of those folks that are living with multiple chronic diseases, get them into medication therapy management to make sure that the meds they're taking for this disease aren't interfering with this disease, et cetera, et cetera. Fairly simple stuff. Moving along, strengthening prior authorization. This is some of the good stuff, right? This has certainly been very, very hot in the news the last couple of weeks, right? With the whole tragedy that's happened in the last couple of weeks. Everybody's been up in arms complaining about prior authorization, claims denial, yada, yada, yada. Well, we got some good news for you. CMS proposes significant reforms to the prior authorization process, requiring plans to adopt electronic systems for streamlining requests, maintain approvals for the duration of treatment, and ensure that clinical decisions are made based on evidence-based guidelines, specifically to address inappropriate prior authorization and utilization management practices that hinder access to care. CMS proposes the following. Number 1, define internal coverage criteria and clarify that MA plans may only apply such criteria when Medicare policies are inefficient. And that such criteria must be publicly available and transparent, based on current evidence and widely accepted guidelines from recognized professional medical societies, and consistent with Medicare's regulatory requirements, right? So they have to define that internal coverage criteria, and it must include those items. Number 2, require that once a prior authorization is approved, it remains valid for the entire course of treatment, preventing the need for repeated approvals and ensuring continuity of care. That one right there is a big one. I don't know how many of the prior authorizations that have been denied. Like if you look at the math, what was it? Kaiser Family Foundation said that 7.4% of all PAs of all prior authorizations were denied on the first push through. Unfortunately, only about 10% of them ever appealed. Of those 10%, over 80 of them were approved on the first appeal. But most people give up after the first one. But I'm not sure how many of those would fit under this statement, but I feel like this would be a very good move in the right direction. So I want to say that again. It required that once the prior authorization is approved, it remains valid for the entire course of treatment, preventing the need to get that PA done again and again and again. That's pretty slick. That'll streamline it, I think. And then just to kind of show you some math, what did they say? I think they said there was like 90 million prior authorizations that were done. I can't remember. I'm kind of going off my top of my brain. I remember looking at the math. It basically equated to about 1.5 PAs per beneficiary. But that there is pretty slick. The next one is that they will mandate that plans provide specific reasons for coverage denials, including the exact Medicare or plan coverage rule or guideline used in the determination, and a detailed explanation of how the criteria were applied. So again, when they deny a prior authorization, they must explain this is specifically why we denied that PA. We have to include the exact Medicare or plan coverage rule that we used in that determination. And we have to provide a detailed explanation of how those criteria were applied. So if a PA is denied, he can't just be like, sorry, that PA is denied. It has to be, the PA is denied, and here's why we denied it. Here's the rule that we're referencing that allows us to deny it. And here's a detailed explanation of how we applied that criteria to this specific case to show you, to reinforce why our decision is correct. Pretty simple. Next one, they have to reaffirm beneficiaries' rights to appeal denied services and require that plans inform enrollees of their appeal rights. So not only, hey, we're denying your PA. Here's the rule. Here's why. Here's our explanation of how we came to this conclusion. But then here's all of your rights and the steps you take to appeal it if you don't like our decision. Seems like that should already be in there, but they're expanding and they're pushing on that a little harder. And then finally, address retroactive coverage denials, particularly for rural hospitals and critical access facilities, by ensuring that utilization management practices do not disrupt payments or access to care.
Fueled by the flight shame.
Additionally, a little comment down here. Additionally, CMS plans to collect detailed information from initial coverage decisions and plan level appeals to better understand utilization management practices. Fairly simple. We got some new AI guardrails. Same thing. Like this is the whole use of AI, the use of prior authorization, all of that's been growing. They're pushing on it hard. And here's another one. Artificial intelligence is increasingly deployed in healthcare, from decision-making tools to administrative processes, recognizing both the potential and risks of AI in Medicare Advantage and Part D. CMS introduced critical guardrails for MA plans to enhance algorithmic transparency, monitor and mitigate potential biases, and maintain human oversight, ensuring that clinicians retain authority over medical judgments impacting patient care. So we've already heard, right? I'm sure you've seen the article. I mean, I posted it in here at one point that United Healthcare was accused of or even getting sued for denying claims through AI. And I want to say, I'm going by memory, I want to say they said like 90% of the claims that they denied were used by AI or something to that effect. And obviously they're going to use it. Everybody's going to figure out how to use AI to their best benefit. It's probably not always going to work great up front, as many of us know. I mean, I've been trying to use AI in my business in different capacities. Sometimes I've been very successful with it. Sometimes it's got some issues and makes some mistakes, and we got to continue to polish it. So they've got some new guardrails. They got 3 primary guardrails. AI and automated systems must be utilized in a manner that preserves equitable access to Medicare Advantage services. The use of AI must adhere to existing Medicare regulations and prohibit discrimination and promote equal access to MA services. And finally, MA plans, I think this is the best one. MA plans are required to disclose their use of AI tools, ensuring that beneficiaries and providers are informed about how AI influences coverage and care decisions. So they have to use it in a manner that preserves equitable access. They have to use it in a manner that follows Medicare regulations and prohibits discrimination. And then finally, they have to disclose to beneficiaries and providers, hey, we're using AI for these purposes. Here's how we're using it, etc., and how it might influence coverage and care decisions. Pretty simple. I like that one. Moving along, enhanced provider directories for improved accessibility. Now, I just want to remind you, this is a lengthy article, man. I'm probably going to have to cut this off at some point because there's definitely no way we can get through all of this. But this is just based on the Part D portion of the 2026 proposed rule. Okay? Everything that we're talking about falls around that. There's a lot more in that 2026 final ruling proposal. But this is just all the stuff on the drugs for the most part, drugs and MA, like processes, etc. Right? Enhanced provider directories. I went over this in pretty good detail. This one is simple. What they are wanting here is a standardized format for provider directories, right? So they want Aetna, United Healthcare, Humana, Cigna, Blue Cross, whoever it is, when they submit their provider directories, they want a standardized format of how all of those look, right? That way they can easier upload it to Medicare Plan Finder. And I'm hoping that that spills over to other tools like Sunfire, like Connecture, etc. Makes sense to me. Like I'm surprised this doesn't already exist, but that's just a point of show you like how inefficient our government can be, is that they didn't already come up with like, oh yeah, let's make all the carriers submit their provider directory in a standardized format. No, let's just let them send whatever crap they want. And if you're an agent out there that uses some of these tools, like you already know how inaccurate some of these provider directories are, right? I can go on Sunfire and it looks like Dr. Johnson is in network, right? But then I double check it on Humana's site, for example, and like, no, he's not in network. I go to Dr. Johnson's site, he still shows in network. Like there's a lot of inaccuracies, and then ultimately you just have to pick up the phone and be like, hey, Dr. Johnson, do you accept Medicare Advantage from Humana, et cetera, just to be certain. So this, I think, could be a really good thing. I'm surprised it doesn't exist. But again, all they're wanting is they're asking for providers to submit a standardized format. And this is specifically for the Medicare Plan Finder tool, right? So if you go to Medicare.gov, as you know, there's a Plan Finder tool. You can look up all the different plans that are available, punch in doctors, drugs, etc. So again, they want a standardized format for that so that there are less inaccuracies and hopefully just better solid all-around data. And I'm hoping that that spills over to the other tools that we as brokers use, like Sunfire, like Connecture, etc. There's a whole bunch of these. We're getting close to the end of the hour, so I don't want to jump in to too much of this because it is deep. Administration of supplemental benefits. This is probably one episode in and of its own, right? But they are really cracking down on supplemental benefits. There's a lot more reporting that these carriers have to do. The primary thing that they're looking for is they want to see, number one, do the supplemental benefits that you're providing on your plan. Number one, do they have utilization? Is anybody actually using them? But then more importantly, do they have can you prove that they're responsible for positive health outcomes? Is it specific for people that have chronic disease that are helping them, or is that benefit going to be utilized in a manner that will improve their health outcome? And there's a ton of reporting that carriers have to do now. So I don't have enough time to get through all of that one. I'll point that out for you. And then again, I'm going to get this article in the group. You guys can dive into this deeper. This will be an ongoing thing as we get ready for 2026. Because again, this is still just a proposed rule. We don't know if any of this or all of it's going to go into effect. And like I've already mentioned, with the new administration coming in, none of this might go into effect. I don't think that would be the case. I think a lot of this will get pushed through and some of it certainly won't. So that we'll have to monitor this ongoing, and all of this again is for 2026. But we do have until the 27th to comment on it. Improving experience for dual eligible. This is fairly simple one again here. They are now working towards the integration. Like this is the first year where they're really pushing the integration on the dual eligible plans. So starting next month in January, right, any dual eligible beneficiary, if they want to move to an integrated DSNP plan, which means that that DSNP plan actually has the real Medicaid contract in that state or in that region. Right, in this example, I think Texas is broken into 4 Medicaid regions. United Healthcare tends to have most of the Medicaid contracts, if not all of them, locked up. Molina's in there for certain regions as well. So it's going to vary from region and state to state on which carriers. But ultimately, they're looking to shrink the number of dual eligible plans that are available in any given market. Right, they're tired of any given healthcare company, United Healthcare, Aetna, Humana, whoever it is, having all these different DSNP plans out there. Like you got a PPO, an HMO, and HMO POS. Why do you have 2 different DSNP PPOs? this one and that one. They're like, no, no, no. If you're going to have a D-SNP plan, you're going to have one plan in the area. Or maybe you'll have an HMO and a PPO and that's it, right? They're going to eliminate the look-alike D-SNP plans. So at some point in the near future, probably 2026, if I remember correctly, is when this really starts to crack down. You're going to look in a zip code and you're going to see maybe 2 D-SNP plans, maybe 4 D-SNP plans at most. You're not going to see 15, 20 different D-SNP plans. You're going to see probably 2 to 4, depending on how many carriers are integrated, how many or look-alike plans that they're going to get rid of, etc. Right? But this is a thinning of the herd of the D-SNP plans. And I agree with it to a large extent because I feel like the highest amount of churn that we have in this business is on the D-SNP space. A lot of these folks they're a little more susceptible to efforts to change their plan, right? Let's just say it that way without calling anybody out or making anything negative about it. I mean, currently they can change every 3 months, right? Every quarter they get an option to change other than the AEP quarter, which still is kind of included. But next year they're going to be able to change monthly, but that monthly change is only if they're moving into an integrated plan. So, and somebody brought this up in one of the Facebook groups, but if I'm an insurance agent out there and I'm doing work in the D-SNP space, I want to make sure I know for a fact which carriers have the Medicaid contract, the integrated contract, because that's the product that's going to last, most likely. That's going to be your long-term product. So if you want higher retention in the D-SNP space, lock those people into the integrated plans that are in that area, get them on your book, and it's going to be harder for them to change, right? Because they're tired of the amount of churn that happens in the D-SNP space, so they're trying to reduce that. One of the best ways to reduce it, let's reduce the number of plans. And eventually they're going to get it down there like either, look, you're on the United Healthcare plan or the Molina plan, as an example. Pick one. Which one do you want? Or you're just on original Medicare and Medicaid, right? They're tired of seeing 15, 20 different D-SNPs in an area. Moving along, promoting community-based services and enhancing transportation or transparency, of in-home service contractors. This is another deep one that goes through coding, etc. In-home supplemental benefits. Again, they're looking, again, to make sure that number one, the providers are correct. Number two, the information and the activity, I should say, is being utilized at a level that actually promotes a higher health outcome. Pretty simple. Additional MLR reporting, right? They're codifying a lot of different MLR reporting for these people, as well as risk adjustment data. Those are kind of the boring ones down there. But these are the ones that, these increase costs for these carriers, right? If they have increased reporting they have to do, they got to hire more people to help with that administration. That raises costs, reduces, etc. So this was a pretty deep one. Good article. Like I said, I'm going to put this in the group for you guys, but it goes through a lot of the key proposals from there. Doesn't talk about any of the marketing stuff. Most of it's around the Part D side of things. I spoke a little bit about some of the marketing changes that they were looking at making when I did the full video, and we're going to dive into it deeper. But again, ultimately, we have until July or January 27th to comment on this final rule, and who knows, the whole damn thing could get pulled back with this new administration. So stay tuned for more. We are at the top of the hour. That episode went a lot longer than I thought it would. So I appreciate you guys tuning in. Have yourselves a wonderful, wonderful Tuesday, and we'll see you next time. Tuesday training, hopefully with less jazz.
And this is, of course,